What are some choices you need to make about your birth? And what are some priorities you'll want to include in your birth plan? Hi, I'm Melissa Evans. I've been a childbirth educator, doula, lactation educator, and a couple other educators in there too, since about 2004. I love my job, and I know how important it is for families to have quality childbirth classes. I also know that most families have a difficult time squeezing them into budgets and schedules, so I'm going to offer them here for free, where you can watch them anytime you want. Please know that I am not a lawyer or a medical professional, so do use some common sense and talk things over with people that you trust. But for now, let's look at some important decisions that you need to consider. In my last class, 15 tips on writing a birth plan that'll get read and honored, I mentioned that we'll talk about the what to put in your birth plan. Here it is, as promised. This is going to be a rather lengthy class. I apologize, there's a lot of information. Here are 22 cards that are each a consideration for you. Now, when I would do an in-person class, I would actually just kind of talk about it, and I would have my students list these in priority, from the highest priority down to the lowest, and that was their job, not mine. But technology isn't quite that cool, so you're going to have to put up with me putting these up by my thinking, which means it's my opinion, and you are certainly welcome to have yours. My goal here is basically to get you thinking and get some information to you, not necessarily to dictate how you should think and what you should feel. So some of these you're going to notice are quite interconnected, and one of your assignments will be to effectively do this on your own afterwards. So the first card is to not be offered pain medication. Most of my students in my in-person classes are in fact looking for an unmedicated birth. So if that's you, this might be something to consider. If you are looking forward to an epidural, then this is clearly going to be at the bottom of the list, and that's okay. But for those who are trying for an unmedicated birth, to have the nurse go, "You ready for an epidural? Would you like an epidural? So how about that epidural?" It can be really disheartening and almost feel like, wow, am I doing it wrong? She clearly thinks I need an epidural. I guess I do. So that can be a little bit not so fun. That being said, when I talked about the birth plan and having your overarching theme stating that you want a natural birth, most care providers, if they know that, they're not going to be a jerk here. So personally, I'm going to put it a little bit lower, and we'll keep going. The second one is to choose my labor position. We already have 2 classes up, 13 positions in each class to try during labor. When you get to move, it helps labor go faster and be far more comfortable, and quite frankly helps the sanity. This, for me, is a pretty darn high priority. Have minimal electronic fetal monitoring, or EFM. More accurately, it's cardiotocography, meaning it's measuring baby's heart tones and the strength of the uterus. In general, it is 2 belts that go around mom's body. There is one sensor at the top that measures her contractions, sort of. It measures change that's going on. So it could be mom coughing, it could be baby kicking, but ideally some movement for contractions. And the bottom one measures baby's heart tones. These are usually connected via cord to the machine that runs the strip. In local hospitals, it is very common for moms to be on the electronic fetal monitor for 1 hour, and then if everything looks good, they will do 15 minutes on and 45 minutes off, so that's kind of nice. The tricky part here is when we're looking at the difference between intermittent monitoring and continuous monitoring. Babies need to be monitored. We're not going to suggest otherwise by any stretch of the imagination. But continuously monitoring doesn't actually do any good. Hensy Goer, Obstetric Myths versus Research Realities, and I think she's coming up with a new edition too, so this might be slightly outdated. But she talks about how every single study done comparing continuous fetal monitoring to intermittent has shown that it does not improve the health of mother or baby. The only thing continuous fetal monitoring does is increase the rates of cesareans. The other thing that this does is also limit the ability to move, even if there are telemetry units, so no cords. It still has the increased cesarean rate. That doesn't actually change that. and it makes it really hard to move. So for me, this is kind of high, knowing that the effect is an increased chance of cesarean, and I've already done that once, avoided it in the next 2 births. So this is pretty high for me personally. Again, you decide for yourself. Card number 3 is taking pictures and videos. Who wants pictures of that, you might ask? Well, it's not like back in the dark ages where you had to go to the drugstore and have the film developed. So it's just on your phone. It's all digital. You do not have to post it on Instagram. It's okay. And you can never go back and get those pictures. So I would suggest letting the pictures, yes, even the full on graphic, oh my gosh, that is a baby coming out of a body, pictures. Key thing, if it's in black and white, poof, it looks artistic. It gets all the gore out and you're good to go. Many hospitals will not allow videos. Talking to one nurse, she mentioned that a hospital was sued using a video. It made them look really, really bad, but then it was discovered that the video was actually tampered with. So they just kind of cover their bases by not allowing them. That being said, as much as I love the pictures of my birth, I'm going to put this on the low side because it simply isn't typically a battle. Doctors don't care. So if they're not going to push back, if it's part of the routine, then as far as birth plans go, I'm going to let it be kind of low. Our next card is avoiding forceps or vacuum. This is also known as an assisted delivery. Originally, doctors used forceps. They're kind of like salad tongs that would be inserted and grab baby's head to pull baby out. And then they were hurting babies a fair amount. In fact, Sylvester Stallone's damage is actually a forceps injury. So then care providers were going to vacuums, but that's actually causing bleeding in bad places. So they're even going back to forceps again. I think both of them are kind of not fine, I'll be honest. So I'm going to put this at the top. Maybe in here. We'll figure it out later. If your birth requires an assisted delivery, I would highly recommend getting your baby to a chiropractor as soon as possible. It is a forceful procedure. It can sometimes help prevent a cesarean, and it's not to be taken too lightly. Next is the choice to wear your own clothes. In our episode 21 Essentials to Pack in Your Birth Bag, we talked about the concept of wearing your own clothes. It makes you feel feminine and powerful, unlike a hospital gown that is designed for sick people. So definitely some bonuses there. It will often get dirty. There are official clothes specifically designed for labor. Some of them are skirts that go underneath and have full access to the belly for monitoring and even to the back for epidurals if necessary. And other ones are basically glorified hospital gowns with slightly prettier prints. So choose wisely, make sure it's still functional. I'm going to put this pretty low on my list for 2 reasons. The first is care providers don't care. They're not going to fight. It doesn't matter that much to them. And the second is most moms are in their birthing day suits, and are naked by the time baby's coming anyways. The next card to consider is avoiding an internal fetal monitor. This is an internal fetal monitor. When my childbirth educator described one, she said it screwed into baby's head, and I thought, oh my gosh, what is this Frankensteinian torture that we're doing to infants? And then I saw one in real life, and I was like, oh, well, it's not that bad. And when I showed this in class, people were like, oh my gosh, so I don't really want this to be my opinion of it. This is what it actually is. It is the single coil of a spring. It does in fact puncture baby's scalp. It goes underneath to get an exact reading on baby's heart tone. This is actually left in, which means there is a ramp for bacteria. So the rate of infection chances do go up. There's a second part that can also measure mom's contractions. It's a little pressure water balloon, if you will, that gets inserted. And unlike the electronic fetal monitor, which just uses Doppler, this one is actually measuring pressure, which means it's a much more concrete, factual number that it's offering. Movement clearly goes way down with these things stuck inside of mom. If baby's heart tones are on the sketchy side, or if they're having a hard time gathering them, this can save mom from an unnecessary cesarean. However, it's not particularly comfortable for either of the parties. I'm gonna put this pretty high. All right, next on our tour is avoiding labor augmentation. Augmentation is taking something and making it stronger. So in this case, it's a labor that's already begun. Contractions are existing, and we're going to do things to them to make them stronger and closer together. These are typically the same tools that are used for induction, but labor has already started in and of itself. Not my favorite thing. I feel like labor is intense enough, and making it harder doesn't sound like too much fun. There are some reasons why it might be beneficial to make things progress faster. I'm going to put it right about there. Avoiding a routine IV. So care providers very much like to have access to a vein just in case bad things happen. And I get that. They need to feel like they can do their job and save you if saving is necessary. However, there are some risks. With an IV, once again, we have a pole. It's a tree. Very much limits movement. Not my favorite part. Also, there's going to be all of this extra fluid in mom's body, which makes for really fascinating looking ankles the day after, but not just ankles, breasts as well. The engorgement after that can make it really hard for baby to latch on because the nipple is pulled so flat. Oh, and all of that fluid doesn't just go to mom, some of it goes to baby too. So now baby's weight is inflated. It is considered safe for babies to lose up to 10% of their birth weight. And once they lose more than that, care providers rightfully become worried and start insisting on supplementation and other things that can disrupt breastfeeding. But what if baby wasn't actually losing weight? What if baby was just peeing off the IV? The good news is most care providers are more than happy to allow for a simple saline lock, or HEP lock, or buff cap. It depends upon where you're giving birth to what they call it. But in that case, the IV is started, so the needle is used, the puncture is made, a catheter is left in, nothing sharp, nothing pointy, nothing that can hurt you. And that catheter is left in with a little tube that gets taped. Now, care providers have instant access and mom can completely move. As much as I don't like routine IVs, I'm going to put this pretty low simply because most care providers are perfectly happy with the lock instead of doing this. Here we go. Having access to a shower or a bath. We've kind of talked about how important it is to labor at home as long as possible, so this might not be even a concern. Most care providers will let you labor in a tub or shower, although it's less common to allow for a water birth, actually giving birth in the tub. Probably not in the shower. That would not be comfortable. I can't really find many benefits to that in general. So for me, I'm going to put this pretty low, but if your birthplace only has like 1 or 2 labor suites that have the really nice pool, this might be a much higher priority for you. But laboring in the tub is sometimes referred to as the midwife's epidural because it can be so relaxing. This one, delayed cord clamping, is a pretty long topic. I'm going to do a whole other class on 3rd stage labor. So this is the abbreviated version, and keep watching for the next class. I'm going to spoil this so I can talk with my hands, and I'm going to put it up pretty darn high for me. So when baby is inside mom, they're basically an aquatic critter. They do not have to breathe through their lungs. Once they are born and are outside, then they have to figure out this whole breathing oxygen thing. Their entire respiratory system has to go through this massive change. And when this cord is intact, we have a 1 to 2 minute insurance policy that baby's still getting oxygen. That's pretty important. Once this is clamped, not cut, but clamped, baby's only choices are breathe or die. That's kind of brutal. If it's left intact, it lets them gently come into this whole new experience and try to figure things out. Also, when baby is first born, about 25% of their blood volume is in the placenta. That means if that is clamped immediately, they are denied 25% of their blood volume. That's like being born with a hemorrhage. I find that to be significant. So some people are happy waiting 30 seconds. Some people want 5 minutes, an hour until the placenta is born, until the cord stops pulsating. There's all kinds of ways of looking at that. We'll go into more details later. But talking to your care providers about this one might be worth doing. My poor sweet mother has to put up with me. So when I was pregnant with my first, we are out at a family breakfast at a diner, and she kept telling me how make sure they cut you big enough. They didn't cut me enough, and I tore, and I had to sit on a donut for a week. So yeah, we're in the middle of a diner, and I have to give her this whole demonstration. I'm gonna set this aside for a sec. Imagine this is your perineum. Pretty strong, right? However, once a cut is made, not so much. Back in the olden days when they would cut moms to prevent those massive tears, in all honesty, they were probably causing them. There are a couple other risk factors here too. A cut will go through cells indiscriminately. A tear will go around cells and go through weak cells. A cut will go as far as the care provider wants. A tear will go as far as baby needs. Doctors like cuts because they're crisp and clean and you can easily match them up for sewing. But a tear, being zigzag that it is, you can actually make sure that it is puzzle pieced together. So if given the choice between an episiotomy or a tear, well, quite frankly, I'd pick none. Thank you very much. Door 3, yeah, let's do that. But unless the tear looks like it's going north, I would rather tear than be cut. The good news is this is not terribly fashionable anymore in the obstetric world. Most care providers don't do it. So even though I really don't like the concept, I'm going to put it pretty low because it is not particularly common anymore. Thank goodness. Next on our tour is avoiding an amniotomy, or breaking the bag of waters, or rupture of the membranes, or AROM, artificial rupture of membranes. This is an amni hook. Many people think it looks like a crochet hook. I don't know, it reminds me more of a Tupperware orange peeler, to be honest. This is actually relatively sharp. This is a single-use one that I purchased for $2 for the sake of class. A care provider would insert it in, guiding it with their fingers, and feel for the sac and grab it to puncture the sac to release the waters. Typically only the forewaters because that's what they can get to. So why would a care provider want to do this? Isn't that a key question? Breaking the bag of waters does increase the intensity and frequency of contractions, usually. Not always, but usually. But with those more intense and more frequent contractions, statistically speaking, labor is only sped up by 15 minutes. That intensity is also felt by the baby, who instead of being cushioned by that water balloon is now experiencing the contractions pretty significantly. If baby is very high in the pelvis, this does run the risk of the cord coming down in front of baby's head. This is called cord prolapse, and it is a true obstetric emergency. So although this is relatively benign, it's not one of my favorite things. Another potential risk is doctors will be afraid of infection because the bag of waters is no longer intact, protecting the baby. So sometimes there is now a clock on mom. If that baby is not born within 24, maybe 48 hours, it's an automatic cesarean. So I'm going to put it right about there for me. It is actually kind of a form of augmentation or even induction in times too. Avoiding frequent vaginal exams during labor. Let's face it, nobody likes these things, but it provides a number that care providers can write down. Make sure you watch the class, 6 things you can learn from a vaginal exam and why you might not care. Because labor is not linear, this information might not be terribly useful. It can be disheartening. So these are not my favorite things, but you can also just simply say, no thank you, when one is offered. The ability to play your own music. I love music. Again, we already talked about having 2 playlists, the really relaxing and soothing one and the really upbeat, get this party started one. Music can be very, very important. I'm going to put it low on the list simply because no care provider will ever fight you on this. So, having access to eating food and drinking water. Unfortunately, in many birthplaces, they still implement the NPO, nothing by mouth rule, or only clear fluids, which is Really frustrating because science does not support that. Their reasoning is that if mom needs a crash cesarean under general anesthesia, they would rather her stomach be empty. Okay, but if someone was in a car crash after leaving an all-you-can-eat buffet, I'm pretty sure those surgeons are smart enough to figure it out. So why do we have to treat laboring moms as if they are pre-operative patients? Also, by denying mom the nutrients and the calories and the energy that she needs, we're actually increasing her chance of needing that cesarean. So it kind of becomes a self-fulfilling prophecy, and not in a good way. I'm going to put this a little bit high-ish. However, if one has labored at home as long as possible, this might not be quite so important, because usually by really active transition labor, mom doesn't want to eat anyways. Where? I would rather be able to drink than have an IV. See, look at that, solves both problems. Choosing our birthing position, the pushing position, how the baby will actually emerge from the body. This is highly connected to the episiotomy. It's also highly connected to assisted delivery. So I'm going to put this higher than both of those because with good positioning, we can avoid those other two things automatically. I'm going to put it a little bit less than our labor positions, simply because usually we're in first stage labor longer than in second stage pushing. Avoiding a labor induction. For me, this is going to be pretty darn high, because with labor induction comes an automatic IV, which reduces our ability to walk. It typically comes with continuous fetal monitoring. It typically is the beginning of the slippery slope that leads us into the operating room. Not always, obviously, but it is a common first intervention that starts us on that path. And I'd rather just not get on that path at all. Also, with labor induction, we are taking a non-laboring uterus and forcing contractions to start. There's some evidence that it's actually baby's brain that initiates labor, so if baby hasn't initiated it, there might be a reason, and I trust babies. So with this, we are not allowing baby to prove that baby is ready for the outside world. Now we come to the crux of the matter, don't we? Avoiding an unnecessary cesarean surgery. For almost all of my clients, this is the top, and having had the crappy cesarean, yeah, that's kind of at the top of my list as well. We like the ones that save lives, absolutely. It's the unnecessary ones that we're trying to avoid. And the tricky part here is that oftentimes the cesarean in the moment is necessary. But what on the path led us there that made it necessary then, where if we had done something different, it wouldn't have been? And again, this is why choosing that care provider is so stinking important. If they are accustomed to inducing at 39 weeks, this chance goes way up. Having birth partner with mom at all times is typically even above cesarean. Because even if you're in the OR, having the person that you love with you matters. And making sure that the partner in this whole parenting journey actually gets to see and experience the birth in some way is really important to them as well. So that one goes even a little bit higher, which leads us to having a healthy baby. This is, of course, top of the line. It does not get any more important than that. That is both our weakness and our vulnerability. We will literally do anything for our children. It doesn't quite matter what it costs. So that's the ultimate goal here, of course. And the last one is having a healthy mother. Most moms are happy to do this. Most partners are not. This is the only time I will let you do them side by side. There, because you both matter. In general, whenever I've done this in class, these top four are pretty stinking standard. There was one incident with a mom who was planning a vaginal birth after cesarean, so her first birth was not what she wanted and ended in an operative birth. This went to the top, and for her it was to heck with the partner. As long as she avoided that surgery, that was a higher priority. And with her experience, that made sense. I had one couple who put this at the top. because they felt like without having delayed cord clamping, you wouldn't have a healthy baby, which I thought was an interesting perspective. There really aren't any right or wrong answers here, as I mentioned. I just want you to think and to study and to know what these things are so you can make an actual informed decision. So down in the comments, there is a handout which will have all of these. Please, moms, print this thing out and jot down your notes, your thoughts, I don't know, a scale of how important it is for you from 1 to 5, smiley face system, whatever makes you happy. And partner, you do the same. Do those individually and then come together and discuss it so you know where the other person is, so that partners can support you properly, so that moms know what's important over there, so that everyone walks away from their birth feeling happy and confident that the choices they made were in alignment with their personal family values. And these are just choices for labor and birth. We'll talk about other ones for pregnancy and then the postpartum period as well, because this whole parenting thing is intense and knowing your choices really is important. So what do you think? It was a bit of a brain dump. Any light bulbs go off for you? Any adjustments to your birth plan need to be made? Let me know in the comments. Please like this class, share it with your friends, and be sure to subscribe. I'll be posting new classes every week, and I don't want you to miss out. Until next time, know your options and own your birth.